All right, just a small update. Firstly, to say that diagnosing TB in people living with HIV and AIDS, especially those with severe immune depletion or advanced HIV disease, can be a very complicated process, as most of the tests that we use have a very low sensitivity in patients who are likely to be smear negative. So if you look at your sputum smears, the previous AFB test that we used to do, that test is good in HIV negative patients, but for HIV positive patients, because they are not coughing out a lot of TB, they tend to have negative smears. The same gene expert, including your LPA, those kinds of tests are very good in HIV negative patients, but in patients with advanced HIV who are likely to give you a negative smear, a negative gene expert or a negative LPA test does not exclude TB, right? So if a patient has TB symptoms and you suspect TB, and your tests are not conclusive, you cannot just say, no, they don't have TB. You have to look further, right? And there is now this additional test, which I think I need you to be aware of, but importantly, just for you to know how to use LAM in a clinical setting. It is a point of care test, like your urine test, pregnancy test, which can really improve your diagnosis process and also the turnaround time in terms of the results, because you'll have the results immediately and you'll be in a position to decide, who then needs to be started on TB treatment or not, right? So firstly, in terms of the LAM test, right? It's important that you differentiate two settings: patients who are admitted and patients who are being seen at the clinic, who are working, ambulatory patients, right? They might be sick, but probably ambulatory. And you would see that to say that step one, assess for TB signs and symptoms. So all patients, as you see, they must be screened for TB signs and symptoms. And for hospitalized patients, by the virtue of an HIV positive patient being admitted, we would then classify them generally to be having advanced HIV disease, and therefore a LAM should be done, right? So you'll see that for a patient who is admitted, you don't even have to wait or check the CD4 count. So an admission is a criteria enough for a LAM, a urine LAM test to be done, right? If you have a patient that you see at your clinic or even OPD, so this is an ambulatory patient, it's not a patient who is admitted, the recommendation is that all patients with a CD4 count less than 200, right, and this CD4 count is not too old, should then be done a LAM test in their urine, right? If the CD4 count is not available, you should request it, And then patients who are ambulatory, right? So who can walk, you don't have the CD4 count, but the patient has advanced disease. Let's say they are classified as WHO stage 3, stage 4, and their CD4 count is less than 100. Those kinds of patients should be considered for a urinary LAM test. So that is very important, right? To say if the patient is admitted, do the LAM anyway. If they're ambulatory, it's indicated for patients who have a CD4 count less than 200. This test was previously indicated for patients with a CD4 count less than 100. We now use the test at a higher CD4 count, a CD4 count of less than 200, right? And then if the CD4 count is high, these patients are not eligible for a LAM test. You might need to use, if they do have TB symptoms, you might need to collect sputum for your TB expert test, or even consider them for the other treatments and prophylaxis as needed, right? So once you have classified your patient by whether admitted or ambulatory, and having made the decision, right, you would then do the LAM test in urine. So you'll collect the urine test and do the LAM test. you would then collect the sputum. So doing a LAM test does not exclude the fact that you have to do, a sputum. So all patients who are TB, who are presumptive TB cases, or what we used to call TB suspects, must still get a sputum test for a TB expert test, and then also a chest X-ray may be done, especially if you are dealing with a patient who has TB symptoms. You've already done your sputums. The sputums are remaining negative from TB expert. An X-ray might add value, though a normal X-ray does not exclude TB in HIV positive patients with advanced disease, right? If you have done your LAM test and the LAM test comes back positive, right, that patient needs to be started on TB treatment, but then you need to follow through on your expert results, right? If the expert results come back and say positive, that patient probably has a TB, but you have an interest to say, is this TB a sensitive TB or a resistant bug, right? If it's resistant to rifampicin, you then need to make adjustments to the TB treatment. So that's very important. If the LAM test is positive, right, but your gene expert comes back negative, right, you would then have to collect further sputums for culture, right? Consider if you need to add antibiotics, to your treatment. Consider if there's other infections, or even do a chest X-ray, right? You must remember these tests are not absolute, right? So a negative gene expert does not exclude TB as much as a negative LAM would not. So if the LAM test is positive and the gene expert is negative, collect culture so that you can tell whether you are dealing with a sensitive or resistant TB bug, and then you need to treat, as needed, right? So and if there's good response to your TB treatment, you should probably continue. But if your patient is not responding, then check for other things. Have you missed community-acquired pneumonia? Is this PCP? Does your patient have other complications that we need to deal with as needed, right? Now, if a patient has a negative LAM, remember, even the same LAM test is not an absolute test. The sensitivities would always fluctuate based on the immune system of your patient. So you would still evaluate your gene expert results. If this test, the expert results are positive, you need to treat the patient, right? Even if the LAM was negative. If gene expert is positive, you treat your patient. If the LAM was negative and the gene expert is positive, so you're getting a mixed result, you still, because the gene expert, if your LAM is negative and your gene expert, the results are negative, you need to still consider the clinical presentation of your patient. If the patient is still symptomatic and you are suspecting TB, these tests do not absolutely exclude TB, right? So you have to look deeper by collecting sputum or the same urine for culture, or whatever specimen you can get from a lymph node, send it for culture, treat for community-acquired pneumonia, assess if this is not PCP, and then do your chest X-rays and decide, what you want to do. But the key message here is that, one, it is difficult to diagnose TB in patients with advanced HIV disease. If a patient is admitted, do your LAM test. If it's an ambulatory case, all those patients at your clinic with a CD4 count less than 100, you may do a LAM test, right, for all those patients. If you do a LAM test, you still need to do your sputum for your gene expert, sometimes X-rays, depending on how your patient is presenting. If the LAM test is positive, you start your patient on TB treatment, you review your expert results. If those results are positive, you continue TB treatment, but you are interested whether this is a sensitive or a resistant bug. So that is quite important. Where the LAM is positive, but the gene expert is negative, you need to also collect sputum for culture, check if you are not missing other infections that need to be treated, including PCP, right? If the LAM is negative, but the gene expert is positive, you treat for TB. If both the LAM and the gene expert are negative, you have to do other tests to try and find this TB, including your TB culture from the specimen that's available, treat them for TB, do your x-rays, and then if they are improving clinically on TB treatment, you are doing well. If they are not improving, you need to look deeper for other things, or even a resistant TB bug. All right. Thank you very much. I'm going to stop there. Thank you.